So firstly, I'd like to say it's lovely to be here. Thank you to the organisers for putting it in such an absolutely stunning place. I've had the most fantastic few days. So to be here from the UK is an absolute privilege, and I would only be here secondary to my co-pilots, so Dr. Anne Hale from the US, who I've been friends with for many, many years, who is my long-term mentor, who has given me all the apheresis knowledge that I will be imparting. And my clinical co-pilot, Katie Brickman, who I would describe as the communal day James Herriot, who treats horses in the Yorkshire part of the UK. So I'm here to present Autologous platelet-rich plasma collection by apheresis and its administration into bilateral stifles in 23 UK riding horses with naturally occurring injury. So, conflict of interest, I'm the director of two companies, one Innovative Animal Supplies in the UK and Veterinary Apheresis Service UK. And Anne Hale is the Chief Veterinary Medical Officer at VetStem, and she's the primary author of the IP for lyophilized platelet products. So this is to introduce apheresis as a PRP harvesting methodology. We have had the word mentioned earlier, which was really nice to see, but obviously by a much more prestigious speaker. And then the use of this harvested PRP in 23 bilateral stifle lameness cases. So currently PRP is collected using single-use commercially available kits, and they have varying claims of concentration, red cell reduction and white cell content. They're used because they allow you to produce autologous content, and that's very much required. They mainly utilise small volumes of whole blood and semi-closed systems and require strict aseptic techniques to be effective. And they provide single doses if we're considering average size joint injections of 2 to 10 mils in the equine, depending on the joint size. They can be stored these products can be stored as lysate, but often there's an inadequate volume to do so, and there's quite a large cost involved if you are talking about larger volumes. When we're looking at placebo studies of amounts that we should be considering putting into these joints, and is this in no way a sort of a statement that this is true, but the placebo human studies indicate a dose of 2.5 billion platelets into the human stifle does give a significant positive outcome. And there is a nice horse study as well, indicating that 2.7 billion platelets into the SDFT for the treatment of tendinopathies has showed a reasonably positive outcome. So apheresis PRP collection, it's a relatively novel way of collecting PRP. I use a Haemonetics MCS machine with a platelet and plasma harness. There's 23 horses in this study that had apheresis performed, and of those horses, 6 were apheresed stable size, so within just a standard size stable, and 17 horses were placed in equine stocks. 15 horses were sedated and 8 were unsedated. The apheresis event took a mean of 41 minutes, and that processes 2.4 litres of blood, giving a final yield of a mean volume of 194 millilitres of product. One horse failed to yield, and that was a PCV fault that we've looked into a lot further, and 4 horses had a truncated collection due to technical error during the machine or catheter flow issues. We do a lot of apheresis PRP quality control. I wouldn't say it's perfect, but it is uniform. We do a manual assessment for platelet swell, platelet count, leukocyte count, red cell count using an IDEX ProCyte machine. The apheresis using those, using an actual sample taken at the time of collection and also from the PRP itself, indicated we get an average, a mean concentration of 4.68 times the starting platelet count of that horse. And red and white cells were undetectable using an automatic process. So the yield, 194 mils PRP in between 40 and 260. 40 will indicate one of the truncated cycles that we had a difficulty doing. And the mean platelet concentration in that was 553 times 10 to the 9 per litre. And that actually would give you a mean of 38 doses of 2.5 billion platelets if we were looking at that sort of amount that we wanted to think about giving. We then split that PRP unit. We've developed a sterile separating system that you can see here that consists of 15 30 ml bags, and we use a space limiting device to allow those to automatically fill to 10 to 15 mils to allow a speedy separation without having to individually weigh everything. We then labelled, sterile heat seal off, label them and place them in a secure Corex freezer box for practitioners. We all know what happens in veterinary freezers. And this allows access and identification for future treatments should they be used. This is obviously looking at the potential for using frozen PRP as well as fresh PRP. And these are frozen just at a standard minus 20 degrees, which is a sort of standard veterinary treatment freezer. And that's obviously sort of just stored within the practice. So the benefits to apheresis that we see, it's a closed consumable collection system, and we use sterile collection packs. So the sterility, because these are usually used for transfusion products, or apheresis is usually used for direct transfusion, you have a step ahead as far as the sterile closed process in these systems. And we are achieving a platelet concentration of 5 times the circulating level in these equines. And we had no measurable white or red cell contamination. We also have suitable volume for immediate and repeat treatments if an acceptable treatment is to use frozen PRP. And this is especially suited to stifle treatments where other methods may require multiple consumables or products to be purchased to treat 4 joint compartments within separate stifles. There are some challenges. So the apheresis machine, the software and the consumables are designed for humans, and they have human safety settings set within them. Post-surgery, these horses have all undergone arthroscopy. We'll go into the cases shortly. They can have low PCVs and low platelet levels. Sedation with alpha-2 agonists and ACP are known to cause a potentially large drop in PCV, and we do see this, and we have measured this, and that can be 10 to 20%, which can cause the machine to default out. And non-sedated horses on the opposite side of that, if you don't sedate them, are then very hard sometimes to catheterize and keep steady for 40 minutes. The whole process relies entirely on exemplary venous access and patency. And just for a UK special, when we get to the winter, the machine doesn't like the cold and doesn't like to work. So the cases summary, we had 23 horses were identified as having stifle pathology via lameness workup between February 22 and April 23. Their age range was 18 months to 18 years, and they were a complete variety between 14 hands and 18. We had English riding horses, so the breeds were all very mixed, or some unbroken young stock that were destined for riding. And they all had bilateral arthroscopy and surgical treatment. Post-surgery, we performed apheresis to collect PRP from these patients. It was administered bilaterally in both medial and lateral stifle compartments, all stifles. And all the horses are now more than 5 months post-arthroscopy and PRP. Standard treatment regime was at PRP at least one occasion, usually 2 to 3 weeks post-surgery, and then there was lameness reassessment scheduled at 12, 24, 36 and 48 weeks. Rehabilitation was standard with the aim to return to ridden work and with an idea of trying to get these horses signed off in 48 hours. Some of them are only halfway through this. So by the actual pathology itself, via the arthroscopy, came from a surgical referral centre. The young horses had growth-related osteochondrosis and chondromalacia. The ridden horses had a mixture of traumatic stifle injury, acute chronic inflammation, fibrillation, damage to ligaments, and chondromalacia in almost all cases. Bilateral changes were documented in all horses. 8 horses were noted to have severe pathology with cartilage splitting, and 3 horses had cartilage resected to bone and carried a guarded prognosis to return to work. The lameness representation was between 1 and 4/5 lame, most of them fit into 2 to 3. 12 weeks checks was available for every horse. 22 horses were sound at the 12-week check. 1 horse that was 3/5 lame on presentation was 1/5 lame at 12 weeks. That was retreated with a further treatment of PRP, which will have been frozen PRP, and at 16-week check was sound. 9 horses, although they were sound, had a retreatment due to vet and owner preference, or to prepare for a competition. Some of these horses were low-level eventers that therefore were going ahead to compete. And we have long-term follow-up of more than 5 months on all the horses. 3 of the early horses have actually been euthanized, and these have been euthanized to completely unrelated issues. Some of these horses were older. They had various comorbidities that have occurred subsequent to being enrolled on the study and have been euthanized because of that. The remaining 20 horses have returned to ridden work, which is appropriate to their age and ability. Some of them are only newly broken. So we injected 5 to 6 mils of PRP into the medial and lateral stifle compartments, which if you go off the means, would have been, 6 mil would have been an average of 3 billion platelets. We performed a total of 130 PRP injections. That's not in the abstract, but we've done them subsequently. 13 horses have had 1 treatment and 10 horses have had 2 treatments. And there's been no incidence of flare in any of those. There's limitations, a lot of limitations to what I'm presenting here. There's no control group. Well, it's a cohort study. It's a very basic study. We have no non-surgical group, so the benefits of surgery versus PRP cannot be differentiated. We've got no arthroscopic or cytological follow-up. Clinical follow-up did benefit from being by one practitioner, but relied on client and vet involvement, and therefore we only have a 12-week reliable follow-up for all of these cases, not all of them. And we have used fresh PRP and frozen PRP, depending on the sessions that I was running the apheresis when the PRP was given, and it was interchangeable. In conclusion, apheresis is a very effective way of producing PRP for immediate and repeat treatments of stifle compartments. It's a closed system production. Performing quality control testing, it allows us to increase confidence in sterility and content. And we found it to be safe in 130 separate stifle compartment injections. So in this small study, we found a very positive outcome at 12 weeks post-arthroscopic surgery and PRP administration in all horses, despite poor prognosis, for return to soundness in a proportion of the cases treated. A lot of further work is needed. Apheresis in veterinary patients is a developed technique in the US, predominantly in dogs and horses, but further comparison of the quality of products produced by apheresis and other methods would be very beneficial. Clinical trials that incorporate set treatment regimes and large numbers of affected patients utilising PRP with known content are needed for efficacy claims. And frozen PRP content and viability, efficacy, storage, requirement and shelf life are not yet well defined for use in the clinical field. There's a few select references there. I'm more than happy to supply more. There's so many when it comes to the different facets of this presentation. And with that, I would like to invite any questions.
Questions?
Thank you. I have a really simple question. Do you have to anticoagulate the circuit like we do with the dogs, and do you have to worry about hypocalcemia in the horses when you do this?
No, not in horses. I am actually a small animal vet, so I actually do perform this in canines quite regularly for the same reason, for intra-articular injection. And if we're looking at we usually only have to put them through 2 cycles in order to give us plenty of PRP to do many repeat treatments. With the horses, we've seen no adverse event. In fact, the only adverse event that we saw was when she had to repeat sedate in order to treat these patients. Repeat alpha-2s would sometimes cause a hive-like reaction. We saw when we were actually treating them, and obviously the citrates going through the system, we saw no adverse event, and we didn't need, and this is Anne's advice, that considering calcium within the horse's circulation is really probably just for size is not necessary.
I have a quick question about the freezing process of the PRP, and I don't know much about PRP, but do you think that platelets remain viable after being frozen in just native plasma in -20?
Yeah, with the frozen, no. I don't think there is certain ways of handling platelets in a manner before you freeze them, to the point that you are likely to get a very transient viability when you defrost and actually reuse these platelets. I would say, though, as a caveat, no, there is unlikely to be active platelets that are actually performing full platelet function when you actually inject them, but you have still got all of that content that's within your granules. And I think that it's anecdotal, but the horse vets that I work with feel that there's an anti-inflammatory effect acutely of giving this. We give nothing else alongside it, and they feel they see that benefit. So I think the content of those is what we're looking at. Dr. Hale is most definitely who I would refer you to for that question, because handling platelets, preserving platelets is most definitely her field.
Thank you.
I loved your presentation. Thank you so much. Those are certainly very impressive volumes that you're getting compared to a lot of the kits that we have here. I did notice that you have no red blood cells and no white blood cells. A lot of our kits do have white blood cells. Are white blood cells, such as monocytes and lymphocytes, which is mainly what is left over, do they act as an activator, and do you need an activation for the PRP intra-articularly?
I think that the jury is still very much out concerning the white cell content of PRP, and we will be actually able potentially to modify that. The kit that I actually use has a second phase leukoreduction filtration. Whenever it pushes through, it actually pushes through a separate leukoreduction, so it just removes everything. We can actually modify that apheresis cycle. The MCS machine has quite a lot of methodology to actually look. As you heard earlier, it can actually be asked to, well, the MCS actually can be asked to collect white cells. So if we wanted to modify the white cell content, we actually could look at that. For now, because the jury is so out, I'm very happy that what I want to give at this moment is platelets. And I'm happy that what I am giving clinically at this point is platelets. But I'm watching the literature very, very carefully concerning that, because I think there is just a lot of work to find that very sweet spot between exactly what we need is still very much unknown.